Okay, welcome to another exciting episode of the Nailed It Orthopedic Podcast. We have another amazing guest here on the show today. We're going to talk about kind of the intro to knee arthroplasty. We recently did hip, and now we're going to do the knee. We got to be complete here, so here we go. And I would like to introduce Dr. Harb. How you doing, sir?
Very good, very good. Thank you for having me. I'm very excited to kind of delve into this topic and, clear up some questions that anyone may have, or kind of make just the topic in general a little more easy to understand. I know when I was an intern in orthopedics, I was like, why are we making this cut? Why are we making that cut? Why are we doing the balancing? So it can be a little bit confusing to understand, but I think hopefully by the end of this, we'll have a good, easy definition of why we do these things.
Absolutely. And, Cody is pretty much learning just from like this his first day. So I'm glad that you're here to explain it to him.
There we go.
Yeah. But sir, so usually when we get going, we always like to ask some questions about our guests. So my first question for you, and this one I'm actually being kind of selfish here because this is an interest of mine, but in your experience, what would you recommend, or I guess what are some of the qualities that you think a fellowship will be looking for in a resident who's interested in going into reconstruction, adult reconstruction?
Yeah, so, you got to kind of figure out how you fit into the program. So I think what people are looking for are that you're going to be a good fit to the program, but also that you're not someone who needs to be taught how to do a knee arthroplasty. So a lot of these, attendings in the fellowship, they have busy practices. They're booking maybe 8 cases with a flip room. So on the same side, you're there to learn, but you also need to be able to make it go efficient for them. So someone who kind of is self-directed with learning, good hands in the operating room, very motivated, and basically there to make their lives easier and kind of get that operative experience at the same time. I think the other benefit on the flip side to that is the fellow is that, coming in with a good understanding and good hands in the OR, you'll be able to get a lot more experience early on. So.
Yeah, you would definitely expect, after 5 years, you hope you have some of the basics down and just can get the advanced training that you need to be a successful knee or joint surgeon by the time you get to fellowship. So, yeah, awesome. Things I'm gonna definitely keep in mind.
It can be a little difficult sometimes because every residency program is a little bit different, and not everyone gets a good joint experience.
Yeah,
So there's a lot of other, being good at trauma, being good at other services can all kind of fill into that space to make up for it. But, you have to be motivated and you have to be able to, make things go efficiently for whoever you are working for in a joint fellowship.
Right. I think those are all great points. And I think that same mindset can be held if you're a med student working with an intern. You make the intern's life easier. If you're an intern working with the chief, you make the chief's life easier. And you kind of just continue that path. Next being said, next question I have for you is: do you have any lessons that you learned during residency, or something that stuck out to you that that may be from an experience or something that you learned about yourself, kind of going throughout your years in residency?
I mean, we in our residency call room, we had a big sign on the wall that said, "The beatings will continue until morale improves." So I think that residency is hard, but some attendings may be hard on you, but it's all kind of trial by fire. And I think those experiences, taking that 20th consult, 2 a.m. I think all those experiences or if there's an attending surgeon who's really hard on you, they're all doing it for a good reason. And so I think all those experiences combined, really build you into the person and into the surgeon that you're going to be. So, however silly something may sound, if someone asks you to do something and you may think it's, the worst thing in the world, it will help you grow into the person and the surgeon that you're going to be down the line. So I think all those experiences are important.
Yeah, I totally definitely 100% agree with that. And I think that's a great mindset to have, even, if you're on call, seeing consults at 2 or 3 in the morning, having the mindset that, there's always something that you can learn from this patient, or there's always, a skill that you can obtain, by dealing with whatever it may be. So always look for the good in things. And the third question I have, actually, I think Jay, you may have a question for him.
Yeah, for sure. So just to get outside of medicine and things, what are some of your interests that you or hobbies that you like to do when you're not busy with work?
Yeah, so it's kind of funny how things overtake you and with the pandemic. So towards the end of fellowship with COVID and everything going on, I got into golf. It got into a pretty bad habit where I'd play around and then I'd buy a new driver. My wife didn't really enjoy that too much when I wanted a new club every time I came home. So I got into that a little bit, but the other kind of thing that we like to do on the weekends is hiking. I have a 2.5-year-old daughter and actually another one he's due in 2 days. So we have a little hiking carrier for our daughter. So we throw her on my back and we go for some hikes. So those are kind of the main things.
I think that's cool. No, go,
Cool.
Yeah, go ahead, Jay. It sounded like you wanted to say something.
Yeah, I was gonna say like I want to learn how to golf. It's one of those things that's on my list, my to-do list of, learning to get that down. I just don't really have the chance nowadays, but
Oh, I thought you
yeah.
were about to say you didn't have the coordination. I was gonna say, I know that.
Hey, maybe. Hey, maybe. I don't know, man. I don't know. But maybe one day we'll find out.
You can get out to a Top Golf there easy, and it's only like a couple hours, hour or two.
Yeah, that's a good idea. That'll be a start for me. See if I can at least hit the ball.
Yeah.
Well, let's go ahead and transition into the case or into the talk for the day. So we'll start off kind of with a general case, and then we'll talk a little bit more about total knee arthroplasties. So just say you have, a patient that, Dr. Harb, say you have a patient that comes to your office, 70-year-old male, who comes in complaining of long-standing knee pain. He's seen a physician before in the past. He's gotten multiple steroid injections that don't even last more than a couple of days now. He's tried physical therapy without any improvement, and he's even tried maybe some visco supplementation injections, and he just has continued pain. What are some of the things that you may ask this patient about in the office that you touch on for history and physical exam?
As far as history, it's good to get an idea of how far they're walking, if they need any type of assistance, a cane or a walker. The worst case is if that patient comes in a wheelchair, then it's not a good situation. But the average kind of 70-year-old, maybe weekend warrior, has some knee arthritis, usually on the medial compartment. By the time the steroid injections stop working, that's time to really kind of consider a knee replacement surgery. But the biggest thing I kind of tell them is that, knee replacement's an elective surgery. It's a unified decision between both of us when it's best for you. But waiting is not going to make this surgery any more difficult for me. So it's really when your quality of life is affected, when you have trouble putting on clothes, when you have trouble with your activities of daily living, when your quality of life is severely diminished. And, when you're at that point, I think it's time to really, really consider a knee replacement surgery.
Absolutely. And, this talk, we could go into a whole lot of detail between history and physical and things like that, but I don't think that's kind of not the scope we're going for this particular talk. But let's say we are going down the road of total knee arthroplasty for a patient, and we're getting imaging. So what types of imaging are you usually getting for your patients?
So I like a AP for so a bilateral standing AP, a lateral view, and then a sunrise view. A couple other things that are a little bit important in history. So the big thing now is there's a huge shift to kind of outpatient joint replacement. So, doing these in surgery centers or sending them home the same day. I have some experience in that. The case I did last week was total knee, and we sent them home in 2 hours after surgery. So, history becomes important for that. I don't like to operate on patients who are, we try to get them down to a BMI of 40, kind of modify as many risk factors as we can. Things like A1C, I like it to be under 8. You like their albumin to be optimized. You want them either not to be a smoker. You want them to not be on chronic opioid medications, And the biggest thing is, as far as like doing a joint outpatient, is looking at their age as well. So all those are kind of modifiable risk factors and things that it's important to take into account, whether you're doing this in an inpatient or outpatient setting. But kind of hard cutoffs are the A1C less than 8, and then even if they're 40, 46, 45 BMI and they show some motivation to kind of get that down to a 40, I think that's a good sign that the patient's going to do well after. So I think those are other things in history that you look for and you want to kind of know beforehand.
Yeah, I think all those things are important, just like you're just talking about, because I know infections are more common in patients with larger BMIs. You may have some wound problems in patients that are diabetics or smokers. So I'm glad that we took that second out to touch on these pertinent history things, at least pertinent things to ask your patient and make sure they're optimized prior to surgery so you have the best outcome that you can have.
Yeah.
Anything else that you wanted to touch on history and or physical exam? I know, we always tend to make, look at the patient, check out their alignment, see if they have any previous scars or anything. But is there anything that you wanted to touch on?
Yeah, I mean, I think physical exam is incredibly important as well. In the clinic, you want to see if these patients have a flexion contracture, because the biggest thing is to figure out, one, what are going to be the risks to this patient, and what do you have to do to give them the best outcome, and what modifications do you have to do in your surgical technique. So if they have a flexion contracture, you may be cutting a little bit more distal femur, but you need to know all these things kind of going in. If they have a 15 or 20 degree varus deformity, is that correctable to neutral? If it's correctable to neutral, great. We could probably get by with an implant without a box cut. But if it's not correctable, you may be leaning more to a varus valgus constraint type implant. So I think those are kind of the biggest things, making sure they don't have a contracture, seeing how correctable their deformity is. Other scars on their knee are incredibly important. There was a recent article in Journal of Arthroplasty talking about patients, if they had a prior knee scope, they were at a higher risk for a higher risk for infection than just a native knee. If they've had a uni put in there before, any type of other procedures, all these kind of elevate their risk. And that's something you need to talk to these patients about. Yeah. I think they should be informed of, if they're put into that higher risk category. I think they need to know that.
Yeah, absolutely. So it's always good to go through those things for sure. Anytime you have a patient and you're thinking about doing such a serious surgery, because it can have very bad outcomes from obvious things, now because of the research. We know smoking, uncontrolled diabetes, really super obese BMI, those types of things that, we can sometimes modify to kind of help these patients before doing an elective procedure and give them the best chance of having a good outcome for sure.
You can kind of even go as far as, so for example, I'll give a case example that I had last year, where patient had a multi-leg injury to their knee. They had like 2 revision surgeries after that, and they had probably about 4 or 5 incisions over their knee. So the question is, what incision do I use? And they also had a flap on that knee. So I think for that type of patient, the literature always tells us, like, prevent a skin bridge, make them 5 to 6 centimeters apart, use the most lateral incision, but that doesn't always work out for patients. So for that patient, we got a plastics consult to see what incision was best for that. There's other things, which may be a little antiquated technique, but there's something called a sham surgery, where you literally take them to the OR, make an incision, close it up, see if it heals. If it heals, you go back and use that incision to do your total knee replacement. So all these kind of, you can even go into more detail with these type of things, but so I think physical exam is incredibly important.
Absolutely. So with the the imaging, and we actually did mention those earlier, which imaging that you like to get. So I guess on the specific images, say starting with the AP, what are you actually looking for on those images?
Yeah, so the AP radiograph, I think you definitely need to get a standing radiograph. I like to get bilateral knees on one plate. You'll definitely see it where you may have an X-ray that's not weight bearing, and then you go back and get a weight bearing X-ray, and it's just bone on bone on bone. The deformity is exaggerated even more, and so I think you definitely need that weight bearing film. You know, from the AP, you can kind of see how much wear there is, what their deformity is. If it's a bilateral wear pattern, you could think of some type of autoimmune. You know, if they've had any implants in place, if they've had a tibial tubercle osteotomy with screws in place, those are things you have to think about. If they had an ACL, reconstruction, the hardware may be in your way, and you need to know that so you can have the appropriate hardware in the room for you.
Mm-hmm. Okay. And awesome. So yeah, that's always a good thing to keep in mind. I know Cody, he's a sports guy. So yeah, I haven't seen many cases like that, but yeah, I could definitely see how that would change your whole operative planning if there's, all these previous hardware in there from a ACL repair or something like that. So definitely good to keep in mind. So this is actually going pretty well because we talked about some of the imaging. I guess just specifically, anything in particular you're looking for on lateral radiographs?
Yeah, so actually, so one more thing. When I'm in the room, there's a couple other things you can do with radiographs. So I like to use the Cobb angle tool. You'll have these x-rays up in your room. I draw a line that's straight down the anatomic axis of the tibia and perpendicular, so you can kind of see where your tibial cut lines up. That also lets you kind of know how much you're taking on the medial and lateral side. And then same thing with the femoral alignment. I'll draw a line down the axis of the femur and 6 degrees off from that to get the mechanical axis. So I'll use the radiographs in the operating room as well. But so on the lateral radiograph specifically, you're looking for osteophytes, especially like a posterior osteophyte. That can mean that the tibia is subluxing anteriorly. So let's say you're thinking maybe, oh, this may be a good candidate for uni, but you see a big posterior osteophyte with medial wear pattern. You may think twice about putting a uni in that patient because that could be a sign that their ACL is deficient. So you want to know that. You also want to look at what their native tibial slope is. I try to match that. It can be fairly variable for that. And then the other important thing to look at, especially if they've had prior surgeries, you want to make sure that they don't have a patella baja going on. You know that if you see a patella baja in a lateral x-ray, your exposure is going to be a lot more difficult. So you may need to think about doing something like a quad snip or some type of procedure to kind of further facilitate exposure of the knee, and then it may just not be a straightforward home run case.
I like that. So we're saying I want to touch on the lateral, and then I actually kind of want to go back to the AP and dive into that a little bit more. So we're saying on our lateral film, of course, we want to be on the lookout for where our patella is, our patella height. If we're doing patella baja, you're thinking it may be a little bit, you may think earlier that you may need to utilize some other techniques in order to evert the patella after you do your, parapatellar arthrotomy. Another thing to look for is on the tibial side is look for any posterior wear, which may indicate that you have an ACL deficient knee due to possible chronic subluxation of that tibia. And then you also want to look at your slope, and you want to try to match the either native alignment, or you want to try to figure out what cut you'll have to do in order to make your slope, I guess, may depend on the implant that you're using, but the ideal slope for that implant, is that all correct?
Yeah, I agree with that. Different implants require a different slope. For example, like a rotating platform type implant, the recommendation is to actually cut the slope at neutral. But for other type of implants, you kind of want to match the tibial slope. So I think all those things you said are important.
And Then on the AP, I wanted to take a little bit of time, and if you could explain like the difference between the anatomical access versus the mechanical access, and the part that plays in our, I guess, total pre-op planning for our total knees. And I assume we're probably talking about the a mechanical, like restoring mechanical access. I guess maybe we can actually touch on that, because that's also confusing. If we're trying to restore mechanical access versus doing it in anatomic knee.
Yeah, so, I think this is where it actually gets into the nitty gritty of the procedure and what you're going to do in the operating room. And I think the important thing to realize, especially if you're in training, is that you're going to work with 10, 20 different surgeons, and they're all going to do something different. The most important thing is just realizing, one, to know all these different techniques, because not everyone's right, not everyone's wrong. There's 10 different ways to do a total knee, but understanding the basics and why that person is doing that procedure that way, I think is kind of at the core of this, and breaking down knee replacement into kind of its most basic components, figuring out what goals we're trying to achieve, and then how we're going to achieve them best. So as far as talking about alignment, I think the simplest way to think about it is mechanical access is a line that's drawn from the center of your femoral head to the center of your ankle. That is the mechanical weight-bearing axis of the limb, and that is what you are trying to restore with a knee replacement. So
Perfect.
going in even a little bit more deeper to that, how do we restore that mechanical axis? What are the different techniques to do that? So when we talk about anatomic axis, what anatomic axis is the line drawn down the shaft of the femur, or a line drawn down the shaft of the tibia. This is not the same as the mechanical axis. You do not bear weight in the same direction as a line down the center of your femur. So the anatomic axis is a line down the center of the femur, and the mechanical axis is a line from the center of the head to the center of the knee. The difference between these two lines, the angle that they make, that's usually about 5 to 7 degrees. So that angle is what we're trying to recreate when we make a distal femoral cut. So there's multiple ways to do this. You can stick a shaft down the femur. You drill a hole, you stick a shaft down the femur. That shaft is reproducing the anatomic axis, and then our cutting guide you can actually set to 5, 6, 7 degrees, which that is basically trying to recreate the cut to the mechanical axis. Now, there's other ways to do that, because not everyone's center of the femoral head is in the same location. Someone may have it at 5 degrees, someone may have it at 7 degrees. This is where things like GPS or navigation or robotics can come into play, where it actually, you move the leg in a circle and it actually finds the center of the hip for you, and then it dials in what that mechanical axis is. On average, we're normally cutting the distal femur at about 5 degrees to kind of off the anatomic axis to kind of line up with the center of the femoral head. So taking that even a little further, so the tibia is a little bit easier. The anatomic axis of the tibia is actually straight down the tibia, and that also matches the mechanical axis of the tibia. So they're the same. It's straight down the tibia to the center of the ankle. So the goal in recreating the mechanical axis for the tibia is just cutting perpendicular to the anatomic, which is also the mechanical axis of the tibia. So it's a 90 degrees angle. Now, this isn't always true in every case. If the tibia has a little bit of a bow in it, we still know that from the center of the knee to the center of the ankle is the mechanical axis. So that's why we use extramedullary alignment, where our guide goes around the ankle and goes up to the proximal surface of the tibia, and we can line it up 90 degrees that way. So there's a couple important things about the cut. You don't want to, for example, a study shows that if you put the tibia in more than 3 degrees of varus, it has a higher chance of failure and a poor patient outcome down the line. So you want to be as close to 0 as you can. If you have to err on a side, you can err on the side of varus. It also depends on the total alignment of the knee. But I think the basic concepts are cut the distal femur at about 5 degrees to the anatomic axis, cut the proximal tibia 90 degrees to the anatomic axis. And that should give you a basic good setup for having a good outcome for a knee.
I think that was a great explanation. And just to summarize, so we're trying to restore the mechanical axis of the knee. And so intraoperatively use an intramedullary guide, which typically goes right down the anatomical axis of the femur. And then using that, you adjust your jig and you make a cut in about 5 degrees of valgus, which will help restore the mechanical axis. And that's for the femur side versus for the tibia side, the mechanical axis and the anatomical axis is in line right down the shaft. So you make a cut at 90 degrees. The question I had is, we always hear or see these numbers like 87 degrees and 81 degrees on the the distal femur angle, or where do all these numbers come from? How do they come up with that? Because those are always pop up on pictures, and I remember I was confused. I was like, I thought we were making 5 or 6 degrees of valgus. So how like, where do those numbers come from? Can you explain that?
Yeah, so if you look at that for the distal femur, where it measures the lateral distal femoral angle at 87 degrees, which is normal, the way that number comes about, and a lot of this is more important when you're doing deformity correction in the pediatric literature. It's not so important for the joint replacement literature, but basically the lateral distal femoral angle is at 87 degrees because the joint line is actually 3 degrees off from the mechanical axis. So it's actually, in total, the distal femur is actually 9 degrees of valgus, and the proximal tibia is actually in 3 degrees of varus. So if you cancel out the extra 3 degrees in the distal femur and cancel out the extra 3 degrees in the proximal tibia, if you just cut it at neutral, so you're just cutting to the mechanical axis, you actually cancel both those out. So that makes it a square rectangular gap for your cut. So it's just because the distal femur is in that extra 3 degrees of valgus, and the proximal tibia is in that extra 3 degrees of varus that these numbers come from.
Perfect. Go ahead, Jay.
No, that was good. I mean, I have so many questions. Even if anyone who's done a few of these cases and you're trying to understand, like, I wonder why they're trying to get 6 degrees on this particular jig, and that makes so much sense. You're just trying to restore the mechanical axis, and if you understand the difference between the anatomic and mechanical axis of the femur, boom, it makes a whole lot more sense there. So I'm glad that you broke that down. What is the significance of the posterior condylar axis as well? That's something else that we see, when you read about just the surgical technique of total knee arthroplasty. It's something that comes up. Can you explain that a bit more?
Yeah, so looking at the posterior condyles, they're actually internally rotated about 3 degrees. So when you're so you've made your distal, the way I do, I prepare the whole femur first. So you've made your distal femoral cut. It's 5 degrees. It lines up with the mechanical axis, points straight to the femoral head. Great. The next step is, for me, setting our femoral rotation. So you'll see it in every question. Don't internally rotate the femur. That causes patella maltracking, causes subluxation, risk for dislocation. But why do we externally rotate it to 3 degrees? Why do we choose that number? So that the posterior condyles are actually internally rotated to 3 degrees. So to compensate for that, we're actually externally rotating the jig by 3 degrees, and basically the 3 degrees cancel out, and that gives us a flat cut, which everything we're trying to do is we're trying to get rectangular spaces. So we're trying to get a rectangular extension space. We're trying to get a rectangular flexion space, and this is going to give us a balanced knee, and a balanced knee is going to give us the best outcome for the patient and give them the most stable knee that we can. And so that's why we externally rotate the jig by 3 degrees. Now, the pitfalls that you have to kind of watch out for is if you have a hypoplastic lateral condyle, then the posterior condyle axis is actually more than 3 degrees internally rotated. It may be 5 degrees, it may be 6 degrees. So then we would add more external rotation into our jig. And that makes up for that extra degrees. And so there's a bunch of different techniques to accomplish this. You can take a small little wedge, you can put it into the lateral condyle. You can line up your external rotation with the epicondylar axis. You can look at Whiteside's line to make sure you're perpendicular to that. And some people will even make their tibia cut first and then make their flexion cut off the perpendicular to the tibia so that you have a rectangular space. So there's basically 4 ways to kind of set your rotation. For me, if it's a little hypoplastic, I just like to make sure it's, I may do 5 degrees of external rotation, and I just double check it with the epicondylar axis and with the Whiteside's line to make sure that I'm not internally rotating my femoral component.
Yeah, and actually I think that's pretty high yield about the hypoplastic condyle. So what if you don't appreciate that you have this, that the condyle is hypoplastic, and you don't make the appropriate adjustments, and you treat this like a normal knee? What deformity will you most likely see after you make your cuts, if you don't take that into consideration?
Well, I mean, once you do enough of these, you'll kind of see, and sometimes you can kind of notice, you'll be like, oh, my component doesn't look externally rotated enough, or that's not lining up with the epicondylar axis. But it's not so much deformity, but you will be internally rotating your femoral component, which the ultimate kind of downside of that is your patella, your trochleal and your implant will be shifted more medially, and your Q angle will be increased. And so your patella will be more likely to sublux out laterally. And so you don't want to do a whole total knee and then you find out you're flexing it up to 90 degrees and your patella is popping out laterally. That's like one of the worst complications you can have. The other things, there's kind of slight subtleties to think about. So if you internally rotate your component, then you're actually closing down the medial space a little bit and making it a little bit tighter in flexion on that medial side. If you over externally rotate your component, you're actually closing down that lateral space in flexion a little bit. And those are kind of the subtleties you get into when you're balancing a knee. But really the primary goal and the easiest check is, set your guide at 3 degrees of external rotation. Realize if it's hypoplastic, you may need a little more. And before you pin it and cut it, make sure that you line up with your epicondylar axis and you line up with Whiteside's line.
That was I think that was a great explanation. And so just to quickly sum up some of like how we just kind of talked about how we make some of our different cuts is on our AP is we're trying to recreate again that mechanical axis. So we make our cut in 5 or 6 degrees of valgus in order to recreate our mechanical axis using our anatomical axis as a guide. And then to help control rotation, I know there's a lot of different techniques, but using our transepicondylar axis, our posterior condyle axis is 3 degrees internally rotated. So to compensate for that, we put 3 degrees of external rotation on our jig, or it can be 4 or 5 degrees if their lateral condyle is hypoplastic. But pretty much we want that cut to be parallel to our transepicondylar axis. And we don't want to internally rotate them too much, because then that'll lead to patellar maltracking because you have increased Q angle, and that can lead to complications post-op. And so I guess one of the next things we wanted to touch base on was, can you kind of go over the different types of designs, like the posterior stabilizing and retaining? Can we touch on those?
Yeah, so there's a couple different designs, and they may sound a little confusing because there's so many different ones. Really, you just have to realize that a lot of these designs that don't have a box cut are very similar. It's a lot of marketing tactics by the companies to say theirs is better and they have the best. But, the main kind of constraint is what we're going to be looking at, and we're going to kind of classify these from low constraint to high constraint. So the least constraining implant is an implant that doesn't have a box, it doesn't have a cam and post. And so you may hear these referred to, I would say the least kind of constraint would be a cruciate retaining implant. And the goal behind the design of this implant was you retain your PCL, you keep that in place, that's going to provide some stability, and and then the patient should have a good result with that. There was at one point an even less lower constraint than that, which would be they had a bicruciate implant where you would retain the ACL and the PCL. That didn't work out very well. It had a lot of failure rates. So that was kind of X'd off the market. So next step, we talked about cruciate retaining. You retain the PCL, and then the next kind of level of constraint, you may have heard it referred to as either a cruciate stabilizing, a PCL substituting implant, or you may hear high flex poly, a deep flex poly, a medial pivot poly, a dual pivot poly. Basically, what all these mean is it's conformity of the polyethylene. So those type of implants do not have a box cut, and the polyethylene is just more conforming. So it can be more lift anteriorly and more lift posteriorly. And basically the goal of the design of, let's say, a cruciate stabilizing poly or that category of poly is to try and recreate the protection that the PCL would impart to the knee. So they've done fluoroscopic studies where they take these knees through a range of motion, and normally you get femoral rollback where you go down into deep flexion and the femur actually rolls back. So what they found in these knee replacements is you get paradoxical motion. So the knee actually, when you flex it down, if you're looking at a lateral fluoroscopic view, the femur will actually start to shift anteriorly, and instead of it rolling back, you're actually getting the femur sliding forward. So these highly conforming polys some are built with a 9 millimeter anterior lip to try and prevent that paradoxical motion, to try and impart more stability to the knee. There's been studies in Journal of Arthroplasty looking at in these cruciate retaining and cruciate stabilizing designs, that is there a difference between you actually taking the PCL or leaving the PCL, and they found similar results. So even though the implant was designed to maintain the PCL, whether you release it or you don't release it, there was no difference in complication rates. And that kind of goes into another sector of balancing the knee and balancing the PCL, which we can get into in this talk a little later. So then kind of the next level of stability after the cruciate stabilizing type knee would be a posterior stabilized implant. And so the posterior stabilized implant was kind of the first generation knee to recreate the PCL. And it's been around forever. It's a great design. It works very well, very high success rate. And so there's a box cut and there's a post on the polyethylene, and that post basically tries to recreate the PCL and prevent the femur from sliding forward. So that cam engages the tibial post as you go down into flexion, and so the goal of that is to recreate rollback. Does it actually recreate rollback? It's hard to say. That there is still this want for the knee to go into this paradoxical motion. But that's kind of the next level of constraint. And there is a misconception that if you have a post, it provides some varus valgus stability. A regular posterior stabilized implant, the post does not provide any varus valgus stability. It is literally just there to prevent that anterior translation of the femur. So then the next kind of level of constraint would be a varus valgus constraint. So going from the posterior stabilized implant to a varus valgus constraint, this is one level before that kind of final level constraint, which would be a hinged knee. So the varus valgus has a wider post, and usually in these type of designs, the wide post will fill up the box very, very tightly. And so there is still some varus valgus motion, usually about maybe anywhere from 3 to 10 degrees, depending on the implant. But it does create more stability in the varus valgus plane. A lot of these implants, these posts have to be reinforced with a metal peg that goes in it, and that's to prevent this post from breaking because there's so much strain on it. So this can be great for a revision type case, or a case that you're going into where maybe there's a 20-25 degree deformity and you may need to balance the knee. And it may be impossible to balance. You may still be lax on the medial lateral side. And I think the varus valgus constraint is a great option to kind of deal with that without having to go to a hinge. You know, hinge is a great design, but the longevity of putting a hinge in is not always that good. You know, the way I think about it, and you know, not everyone may agree with me, but you know, putting a hinge in almost makes you a little bit of a second-class citizen, because that's not, you know, these come loose. There's so much stress at the implant bone interface of the hinge design, because it's locked. It's a linked construct, so those forces have nowhere to dissipate except between the bone and the implant interface. And so when you're talking about getting to a hinge, it is a great bailout for some cases. If someone has like neuromuscular disease or some type of insensate limb, or a multi-ligament type knee injury where, you know, nothing else is going to help them except a hinge design, you know, it's great for those cases. But, you know, I'm always hesitant to jump right to it unless it's needed, because there is a high failure rate with those.
And so I did hear you mention about, you know, the patients who would probably have a better, you know, have a more successful outcome with the constrained designs. But who gets the posterior stabilized implants versus the cruciate retaining implants? And are there patients who you wouldn't do those for?
Yeah, so, you know, if it depends on, you know, neuro exam is incredibly important. If someone, you know, has a Charcot knee, for example, and they have no neuromuscular control, or it's insensate, you know, that's someone who, and if they have, usually with that type of knee, it's usually in pretty bad shape. So the ligaments, medial collateral ligaments and LCL ligaments may not be intact. So that's someone I'm leaning towards doing a hinge design. In the past, you know, they talk about that you should do a posterior stabilized knee on a rheumatoid patient. You know, I think that that is true to some extent. I think people are really pushing the boundaries with these newer type knee designs with these highly conforming polys. So, you know, a lot of the times for me, revision, the varus valgus constraint or the hinge design, they're really for my revision type cases, unless it's a really bad primary and it's some type of Charcot joint or some other previous like multi-leg injury. It's really reserved for the revision stuff for me.
And was the thought process, I'm just curious, was the thought process behind the patients that had rheumatoid, for them, was it because the rheumatoid would do so much damage to the soft tissues like the ligaments, you know, like the collaterals, as well as the cruciates, that they may need a higher level of, I guess, stability per se? Is that what the thought process was behind that?
Yeah, that is exactly the thinking behind it. You know, the other thing, if they're a rheumatoid patient, you know, it's recommended some people resurface the patella, some people don't, some people are selective. You know, rheumatoid, I think, is a criteria to resurface the patella because it's a cartilage inflammation disease. These rheumatoids don't have good soft tissues, so you don't want to put in a non-posterior stabilized knee and then show up with a dislocated knee because they're rheumatoid and they have terrible soft tissue. So the extra level of constraint in the rheumatoid type patients is exactly for the reason you said, because they have poor soft tissues.
Makes perfect sense. I'm glad that you went through that. I think the designs is, is something that's pretty basic in the land of arthroplasty, but it makes a whole lot more sense if someone can just kind of break down to you why you use this one and why you don't use that one. And it's kind of like the first steps of kind of planning on what you're going to do. So I think that was good to have that. And you mentioned it a couple of times about balancing. And,
I actually have a quick question before we move on to that, Jay. I know a little bit earlier you were talking about physical exam findings. And so for a patient that comes in with a flexion contracture and say they may have a varus, a deformity, is there a number cut off where you'll say, okay, well, we're not even going to do a posterior stabilizing, we may go to some type of constrained implant? Or I guess how do you venture through that,
Yeah, so I think that, I can just kind of run through some example cases. We had a guy with a 20-degree varus deformity from a previous tibial plateau fracture. And so, in extension, he fell into the defect. But when you flexed him down, he corrected all the way to neutral. And in extension, he was correctable. So, initially, you may just look at the x-ray and be like, wow, that's a 15, 20-degree deformity. I need a VVC or varus valgus constraint for that. But part of the physical exam and realizing he's falling into this defect, he's correcting to neutral, and we ended up putting a cruciate stabilizing type implant, and his knee was completely balanced, completely stable. So I think part of that physical exam and being able to see if it corrects or doesn't correct, if he had that same deformity and he was, let's say, 10 years out and his knee did not correct in extension to neutral and in flexion, he kind of maintained that same varus deformity. I'm going into that case saying this knee is not correctable. It's going to be a difficult knee to balance. I need to have a VVC, a varus valgus constraint implant on backup.
Oh, okay.
But
that makes sense.
One kind of, in my mind, and older surgeons trained on the posterior stabilized type knee made a box cut every time. I think, with the newer generation of arthroplasty surgeons, I think we're on the fifth generation now. You'll see more and more of these, of the PS type implants fading out in primary knees and kind of being saved more for, revision type scenarios. There's a huge advantage, to not making a box cut. I don't know if you guys have experienced, but, one of the complications is if you make the box cut and the box cut's undersized and you go to put a trial implant on and you're smacking it in, one of the risks is fracturing off the medial condyle. And, that's all in part because extra bone was taken. So there's partially a risk with fracture by taking a box. You're taking more bone. So if you have to come back in there and do a revision at a later time, and you have a primary VVC component in, it's a lot harder to go back in and put another VVC component than if you hadn't cut the box in the first place. So you're saving bone. That the other thing that saves time in the operating room, it's one less step. We all know the longer procedures are, the higher the infection rate. You want to get the procedure done, get the patient off the table. And, if all the studies are coming back and saying that these are having the same results and not a higher complication rate, I think there's a lot of benefits to using these more conforming type polys and avoiding the box cut altogether.
Yes, sir. I appreciate that. And I appreciate you answering that question so well. And I just have one more topic before we wrap up here. I wanted to quickly see if we could move on to just some of the gap balancing. I know that's a really high yield topic with total knees, and then a heavily tested question, as well as something that actually comes to play when you're actually doing the case and you have to worry about balancing. Can you kind of talk a little bit about how we balance with our flexion and extension gaps? I think Jay has a something here.
Yeah, so, that's like we talked about at the beginning. Our goal is getting a knee that lines up with the mechanical axis and getting a rectangular flexion gap, a rectangular extension gap. And what I mean by that is that it's equal, that it's balanced in both the medial and the lateral compartment. And if you can come out of the surgery with a knee that lines up with the mechanical axis and it's symmetric on both the medial and lateral compartments, I think you've hit a home run for knee replacement and accomplished kind of the main goals for giving the patient a good outcome. So, there's a lot of things we can do to balance the knee. And so if we're making these bony cuts, let's say we make our distal femur cut at 5 degrees and we make our tibial cut perpendicular to the axis of the tibia, those are our bony cuts. That doesn't affect our balance. Our balance is derived from soft tissue balancing. So everything you do during the operation has some effect on soft tissue balance. You approach the knee, you're getting ready, you make your arthrotomy, you're down, and before you do your medial release, it's important to think about what kind of deformity does this patient have. If they have a mild varus deformity, if they're neutral, if they have a valgus deformity and they're really lax on the medial side, before you do that medial release, you have to think that every soft tissue that you release off the medial side is going to loosen up that medial side. So even from our approach, we have to be thinking about balance. You go down, you make all your cuts, taking out the making sure you get all the meniscus, making sure you don't release popliteus. If you release popliteus, that'll loosen up the lateral side inflection. That's a surgical technique thing that you have to be cognizant of as you work through the surgery and try to balance the knee. And then, as more and more of us are putting in cruciate stabilizing designs, what do you do with the PCL? So some people will leave the PCL. The problem with the PCL is it tightens down the lateral compartment. It also tightens the knee inflection. So if your flexion space is too tight or you're too tight on the lateral side, that's another option. You could release the PCL. Some people leave it. Some people selectively release it, or what you would call balance the PCL, only release it if it's tight inflection, tight on the lateral side. And some people release it every time. So it's really surgeon dependent, but you have to know that those are the three reasons why, or three options that we have and why they're done, and which one are you going to choose when you're out in practice. And ultimately, if you're in a training program, that's what you're experiencing all this to decide, is that what I want to do or is that not what I want to do? So those are the kind of main things. So, let's say, for example, we have a really big varus deformity and we want to loosen it up. We're really tight on the medial side and we want to loosen it up. What can we do? So you can do a bigger medial release. You can get down to the hamstrings. You can release the hamstrings. You can get to that. We can really externally rotate the tibia and very much release that kind of posterior lateral corner. Posterior medial corner. You can take osteophytes as well. The other technique, if you have a really big varus deformity, there's something called a medial reduction osteotomy, where you actually osteotomize some of the bone off. You shift your component laterally, you downsize your tibial component, and just by doing that, by downsizing the component and taking that bone, you've loosened up the MCL and the pressure on that MCL. So just by that nature of downsizing and lateralizing the tibial component and downsizing the tibia with the osteotomy, you loosen up that medial side. The other thing, make sure your tibial, these are like little specific things that, you may not learn or you may not get told, but for example, if your tibial tray is oversized, that's going to put tension on the MCL. That could potentially add more tightness on that medial side. And so that's kind of more looking at coronal plane balancing, and looking at sagittal plane balancing. Some other things are, look at your tibial slope. If you cut more tibial slope, you're going to loosen up the you're going to loosen up the implant in flexion. If you take more distal femur, you're going to loosen up, you'll loosen up the extension space. So for example, if someone has a 10 or 15 degree flexion contracture, a lot of the times I'll just say, hey, take 2 more millimeters off the distal femur. This will loosen up our extension space, which will allow us to get to neutral, which, that's one of the goals too of these patients is they want to be able to get their legs straight. So I think that's important, but these are all things kind of that stem from that physical exam, stem from that radiographic exam, and ideas that you have to have in your head before you go into the surgery in order to get a good alignment, a good balanced knee. A couple other things, that you'll see on OIG questions is, the flexion space is tight. What can we do? So if you have a size, a size 7 femur on, that number 7 denotes the anterior to posterior diameter of the implant. So if you downsize the femoral implant, you're gonna loosen up your flexion space. I would say the most common time that is used, the upsizing or downsizing of the implant would be in a revision case. A lot of the times when you do revision cases, the underlying problem is that you're loose in flexion, so you may want to upsize your femoral component and add on some posterior augments. But those are kind of like the basics, bread and butter basics of balancing the knee and kind of what you have to think about to give a good rectangular flexion and rectangular extension space. Yeah, go ahead.
I was just going to say, like even mentioning the change in the size of the prosthesis is just because the main difference is in the AP diameter. Is that correct? And that's why it makes a difference in more so the flexion gap, but not so much the extension gap. Is that right?
Yeah. So the distal aspect of the implant is always the same. It varies from company to company, but so for example, the implant that I use, you put the implant on, doesn't matter what size it is, it's adding 10 millimeters to that distal femur. So as you go up in number from a size 1 to 2, 2 to 3, 3 to 4, you're growing anterior posterior, but you're not adding anything distally. And so that flexion space is slowly tightening and slowly closing down, but you're not really affecting the extension space because it's still 10 millimeters of metal on the end of the femur.
Yeah, I think that was a pretty easy one to catch on the questions. And so, yeah, we actually have a slide up on YouTube for those who might just be listening on the podcast. But there's like these scenarios that you see come up with the questions all the time. And are you able to just kind of run through them rather briefly, if possible?
Yeah, so if you're tight in extension, tight in flexion, you want to do something that affects both gaps. So, what affects, the easiest way to think about it is the femur, you can individualize extension and flexion. The tibia, whatever you do on that side is going to affect both. So if both are loose or both are tight, how will we do that? So if you're tight in extension, tight in flexion, take more tibia and that'll loosen you up in both. So then the next kind of scenario is if you're loose in extension and loose in flexion, you want to tighten up both of those so you can add more poly, which is the easiest way. Let's say you're in a revision scenario and the company only makes the poly that it goes up to 20. So what's the next option? So companies have augments for the bottom of the tibia where you can add 5 or 10 millimeters to the tibia or base plate and you can downsize your poly. So if you're loose in both, you want to do something on the tibial side, the easiest is upsize the poly for that or put augments under the tibial tray. If you're tight in extension and normal flexion, so what can we do to loosen up the extension gap? So if you're tight in extension, what's happening is you have that flexion contracture and you're not getting out all the way to 0. So you want to take more distal femur. The distal femur is going to affect the extension gap. You take more distal femur, that'll loosen you up in extension. If you're normal extension and you're tight in flexion, so this is kind of I would say this is probably the most common scenario. If that happens a lot. So the easiest way to loosen up your flexion space is you can cut more slope. You can take the PCL. It depends what side you're tight on. You're usually not symmetrically tight. Usually it's one side or the other. So if it's on the medial side, you can do more of a medial release, take posterior medial, capsule and corner. If it's, you could do that medial reduction osteotomy we talked about. If you're tight in normal and extension and tight in flexion on the lateral side, you know, popliteus is a, if that's tight, if the knee is tight in flexion on the lateral side, you release popliteus, that'll open that up a little bit. You can make sure there's no osteophytes over there. You can do some release of that posterior capsule, which may help if you're tight on that lateral side. More for the extension space, you can pie crust the IT band. But you know, I think the biggest things for being tight in flexions, the tibial slope and the PCL, recess those. If you're normal in extension, but you're loose in flexion, you know, I would, for this one, I would build up the flexion space. So, yeah, you know, put in a poly, upsize your poly. So that'll tighten you up in both, which would make you tight in extension. And then you can take a little more distal femur. So I would even that out. I think that's the easiest way to deal with that one. You don't want to be loose in flexion. So the best test to make sure you're not loose in flexion, put the knee in a figure 4 position. If you have a post, make sure the cam's not jumping the post, make sure the knee's not dislocating. You don't want to leave the OR being super, super loose in flexion. If you're loose in extension, but you're normal in flexion, you know, the option for this would be a couple things. So you can add on augments. You'll obviously have to use a revision type implant to do that, to build up your distal femur. And then if you build up your distal femur, this will tighten you up in extension. The other trick which you can use is you can actually use cement augments. So if you don't mallet, if you get a good press fit, but you don't mallet the femur all the way down, you can actually do a kind of pseudo augment with 1 or 2 millimeters of cement. So, you know, cement's a great equalizer. You can basically do whatever you want with it. So you can let it sit just a little bit proud, not too much. You don't want a massive cement mantle, but if you do 1 or 2 millimeters, that's okay.
Perfect. I think that was good. I mean, you see these questions all the time, and it's probably going to at least be 1 or 2 of them on each OITE exam. And if you know it, it's like a quick point for you. And if you spend just a little bit of time, either listening to what Dr. Harb just mentioned or just studying it, it makes a lot of sense. So I really appreciate you going through that as well. And before we close out, is there any, you know, I know there with knee arthroplasty, you probably could have a whole talk about complications. You could have a talk about infections. But this was kind of the main things that we wanted to touch on just the intro to total knee arthroplasty. So is there anything else that you think that we probably should mention, Dr. Hart?
No, I mean, I think all this is, you know, bread and butter for knee replacement. You know, there's great articles on JBJS and Yellow Journal that kind of talk about how to approach a knee replacement from start to finish with physical exam history. But just when something happens in the OR, and this is kind of just a general rule of thumb, and you don't know why that was done, either one, ask the question. If you don't want to ask the question, you know, there's probably a video online or probably somebody explaining it, because someone probably had that exact same question. You know, so I think it's important when you don't know things to go out there, seek the information. That way, you know, you can build upon that foundation. Because once you kind of learn all these bread and butter things about knee arthroplasty, you can kind of get into the more complicated stuff, which I find really fun. So
awesome. I think that was great.
Yeah.
I enjoyed the talk and I learned a lot, and probably gonna have to listen to this one over a couple of times just to grab everything. But I think it was some really good basic knowledge to know about knee arthroplasty. So it was really helpful. Thank you, Dr. Hart.
Yeah, that was excellent.
Absolutely.
Thank you, Jay and Wendell. I really appreciate it. This was a lot of fun for me. I love doing the online education stuff. So, I love what you guys are doing. I think keep doing it. This is a great way to provide education.